Welcome, everybody. This is March 25th, 2021, Rush University Medical Center Division of Nephrology Renal Biopsy Conference. As usual, the case has been de-identified, and this will be recorded and posted on YouTube in a week. Please join our channel. We have no disclosures to make. We've got a great case today. I think Dr. Zhang is going to read the protocol.
Yep.
As usual, put your questions in the chat room, and we'll try to get to them and open it up a little bit more at the end to the faculty. So, Dr. Zhang, you want to start the case?
Yep. Patient is a 45-year-old Black woman with a significant past history of lupus who presents for evaluation of worsening proteinuria. She was diagnosed with lupus 10 years ago, at which time she presented with joint pain and a new rash. Her labs were notable for a low C3 at 40, a normal C4 at 20, positive anti-double-stranded DNA at 153, positive ANA, positive SSA. Her serum creatinine was 0.7 milligrams per deciliter. Her urinalysis was bland with a UPC of 0.3 grams per gram. She was treated with prednisone and Plaquenil. She had subsequent intermittent flares that were treated with prednisone. 2 years ago, she presented with shortness of breath and was found to have an acute PE. She was initiated on anticoagulation. Antiphospholipid syndrome workup was negative. Her lab showed a serum creatinine of 0.7 milligrams per deciliter. Her albumin was 3. Her C3 was low at 56, C4 at 22, and anti-double-stranded DNA was 196. Her UA was bland, but now with a UPC of 6.5 grams per gram. She was started on ARB with CellCept with instructions to follow up as an outpatient. As an outpatient, her serum creatinine remained stable. Her urine protein creatinine ratio decreased to 1 grams per gram. She admitted to intermittent non-adherence intermittent adherence to her CellCept of 2 grams per day and her ARB. She remained on intermittent dosing of prednisone along with daily Plaquenil. On the current presentation, she reported worsening joint pains. She denied NSAID use. Her labs showed a serum creatinine of 0.8 milligrams per deciliter, and albumin of 3.4 grams per deciliter. Her UA had 1 plus blood, 2 plus protein, 2 RBCs, 1 WBC, and a UPC of 3.5 grams per gram. Kidney biopsy was recommended. For her past medical history, she has hypertension, she has lupus, pulmonary embolism. She has no known surgical history. For her social history, she was a former tobacco smoker of 2.5 with a 2.5 pack years, no drug use or alcohol use. For her family history, she denied any history of renal disease. There was a positive history of breast cancer in the family. For her revealed systems, it was positive for joint pain. There was no fevers, chills, chest pain, dyspnea, or any GI symptoms or loss of appetite. She had no lower extremity swelling or rashes. She had no allergies. Her current medications include CellCept 2 grams per day, Plaquenil 200 milligrams BID, Valsartan 320 milligrams daily, Nifedipine 30 milligrams daily, Metoprolol 25 milligrams daily, Prednisone 5 milligrams, and Coumadin, which was on hold for her biopsy. For her physical exam, she was afebrile. Her blood pressure was 144/70. Her pulse was 79. She had a respiratory rate of 12, and her BMI was 23. And she was saturating 100% on room air. In general, she was comfortable. She would not appear to be in any distress. She appeared stated age. Her lungs was clear, and she had no increased work of breathing. Her heart was regular in rate and rhythm. No rubs or murmurs. She had no lower extremity edema. Her abdomen was soft, normal, non-tender, and non-distended. She had no focal neurological deficits, and there were no rashes. For her labs, after presenting to us, her sodium was 141, her potassium was 4, her chloride was 106, bicarb of 20, BUN of 16 with a creatinine of 0.88. Her glucose was 76, total protein was 7.5, her albumin was 3.4, her calcium was 9.3, her total bilirubin and her liver enzymes were normal. For her CBC, she had a white count of 3.51 with slightly decreased neutrophil count of Her hemoglobin was 10.2, her MCV was 101, and her platelet was 172. Her coagulation were normal. Her bleeding time was 5.5 and 6.5 minutes. Her lipid panel, she had a total cholesterol of 146, triglyceride of 71, HDL of 26, and a LDL of 106. For her serology, she was ANA positive at 1 to 80. Her anti-double-stranded DNA was elevated at 138. Her C3 was low at 51. Her C4 was normal at 24.1. She had positive SSA. She had normal SSB. Her hepatitis panel and HIV were negative. For her UA, she had a specific gravity of 1.028, pH of 6. She had 3 plus protein, 1 plus blood, but less than 1 RBCs on microscopy, 1 WBC, no cas were seen, and her UPC was 3.5 grams per gram. She had a renal ultrasound. Both kidneys were normal in size with mildly increased echogenicity. The right kidney was 11.5, the left kidney was 11. There was no hydronephrosis. Percutaneous renal biopsy was performed.
Right, any questions for Dr. Zhang or Dr. Baxi, whose case it is?
Do we have any urinalyses going back a few years with regards to her hematuria or pyuria or proteinuria?
Yeah, and so the prior urinalyses really didn't have any hematuria. So the hematuria was a little new in terms of the blood. There wasn't any prior pyuria. And the proteinuria kind of, like I said, it was mostly, less than 0.5 grams outside of the 6.5 when she presented with the PE. And the lowest it kind of got was around a gram, and then it kind of jumped up again to 3.5.
Okay. Casey, you want to walk us through the case?
Yeah, so we have a 45-year-old young woman who has had 10-year history of lupus. For the most part, it seems that her clinical presentation was extrarenal. She had arthralgias and rash, but appeared to be very serologically active with hypocomplementemia and elevated double-stranded DNA. I don't see any additional autoimmune profiles like an ANCA, but now she's reached a point where she's showing some activities within her urine sediment, and even though her creatinine is normal, she's being biopsied to see what lupus lesion she has. And usually in these lupus patients with this degree of activity, when we biopsy them, we find lupus. So I've sort of tried to essentially blame the lupus for the presentation. So the question is which kind of lupus lesion we're going to find. And it's always a little difficult because a lot of these patients are partially or fully treated. So we're talking about somebody who's been on CellCept 2 grams a day and some degree of prednisone for a while. So these are not sort of the virgin cases where you get a fresh case and they're not immunosuppressed. So we have also noticed that in younger specialty patients, a normal serum creatinine does not necessarily mean that they don't have a proliferative lesion like a class 3 or 4, a focal or a diffuse proliferative lesion. So because of the degree of activity that I'm seeing in the blood, I do think that she's going to have a proliferative lesion, 3 or 4. And the degree of proteinuria initially when it was 6.5 grams points towards membranous. So I suspect she would have a 3+5 or a 4+5 lesion in her kidney biopsy, even though her renal function is normal. She also has a positive antiphospholipid antibody syndrome and she's anticoagulated. So the possibility of seeing that on the biopsy is also there, although that I expect if she was not anticoagulated or if her creatinine was up, that would have been more likely. So picking between 3 and 4, class 3 and 4 lupus is a little tough. That's why I guess we do the biopsy. I have tended to lean a little bit more towards a DPGN of an immune complex mediated pathophysiology when I see the complements being very low and anti-double-stranded DNA being very high. But, we've seen these numbers with also a post-immune pattern of injury in let's say, a vasculitic class 3 lesion. So I'm going to go with a DPGN class 4 plus membranous for my top diagnosis for this patient.
Casey, what about podocytopathy?
Yeah, definitely. Lupus podocytopathy is a possibility. I feel that, again, the degree of hematuria that she has. I guess it says less than 1 RBC, but 1+ blood. Usually that's more of a minimal change disease in a patient with lupus, and I expect more protein and no blood, and but it's possible. You can have podocytopathies. She's not very hypoalbuminemic. She doesn't present like that minimal change disease or collapsing FSGS, acute nephrotic presentation to make me think podocytopathy right off the bat. When I was reading this, I was thinking mostly proliferative GN plus membranous, but yeah, podocytopathy is definitely possible.
I think you could see some blood in podocytopathy just because of the background of mesangial, but yeah, just throwing that out there. Dr. Glassick, I have a question for you. You got a patient who's been on 2 grams of CellCept. Does that have any clue to you what you would break through on, or what is 2 grams less likely to have a DPGN or whatever lesion? I mean, does that have any clue to you to what the histologic diagnosis is that this is happening on 2 grams of MMF?
Roger, I'm not sure she's taking the drug anyway. So basically, she may be equivalent to an untreated patient with lupus nephritis. As I indicated in my little note, I would have done an MPA level, because if it was undetectable, she's essentially not taking any treatment for her disease, and that might, modify what kind of lesion I would expect. Even if she were taking 2 grams a day, that's not the max, that's not the maximal dose. So I really think this patient should be considered an inadequately treated patient from the outset.
So we don't, we have not really used MPA levels. At least I have not. Casey, Pravir, Bill, anybody? Have you guys used that much?
I have only used it to check compliance, not necessarily dose toxicity, or I don't think the levels are predictive of anything except for, making sure the patient's taking it. So that's the only time I've used it. And so that's in this case, that'd be a very good idea, because you could argue that, when she went from 6 grams to 1 gram or whatever it was initially, you could argue that she may be a CellCept responsive patient. And then she became non-adherent, at least according to the protocol there. And that's when she kind of went back up to more in the nephrotic range. So in my mind, I was thinking about which lesions are responding better to CellCept as opposed to the opposite of what your question was to Dick.
That's a really good point. So what do you think we're going to see, Bill?
I'm not sure there's an answer to that question, even though it's a good question. That's why lupus is so fun. And that's why we have to do biopsies. I think that, when we see this degree of proteinuria, we often, and without a rising creatinine, our first thing that usually comes to mind is membranous. But it's important, just like what Dr. Gashi was saying, to consider that, the DPGNs, the segmental GNs can all have nephrotic range proteinuria, and the degree of creatinine, just like you said, doesn't really, being so quote unquote normal, doesn't really sway you against a DPGN or a segmental glomerulonephritis post-immune type lesion as well. And I was actually just looking back at, if I could maybe share my screen real quick. I was just looking back at one of our papers to just see what the degree of proteinuria was in segmental and diffuse proliferative lupus nephritis. And we have that here, where on average of all the patients that we had seen at Rush where they have proteinuria, the segmentals, which were considered to be the old WHO3, and the diffuse proliferatives, which was the old 4, had quite a bit of proteinuria. You can see here 3.6 and 7 grams on PC ratio. So the degree of proteinuria does not really sway me towards membranous or away from membranous, or towards DPGN or away from segmental GN. So I think all of those are still in the differential, and I would probably lean a little bit more towards the DPGN just because she's so serologically active with her high double-stranded DNA and low complements. So I would say my number 1 would be DPGN, my number, plus minus membranous. My number 2 would be probably a segmental glomerulonephritis, which could also have membranous as well. And all of those could have diffuse foot process effacement, as well, and it could have coexisting podocytopathy. The classic podocytopathy only is in the setting of either normal or pure mesangial. But if you have diffuse foot process defacement in any of the lesions, then it would be another add-on to call it podocytopathy. At least
Dr.
that's in our
Rubin,
opinion.
Dr. Rubin, you made a comment in the chat board that said Bruce Kaplan has looked at this subject and the results are negative. Could you expand on that? Unmute yourself. Thank you.
Yeah, I mean, we've been using obviously anti-proliferative agents for eons in transplant patients. And when mycophenolate came out, I mean, there was a big push to look at levels and predict the so-called therapeutic range. And Bruce Kaplan, when he was in Gainesville, who has, by the way, a PharmD background, look at it, and it's not helpful. It's not reproducible. I mean, in terms of guidance for therapeutics, I wholeheartedly agree to use it for purposes of knowing whether a patient takes the drug or not. And again, changing the subject a bit, I mean, we have discussed the very well-known dissociation between clinical and morphological findings in lupus. I mean, it's a very polymorphic disease. It's very hard to predict what lesion she's gonna have. I enjoyed the discussion, but just wonder.
Well, we can't go to the biopsy without a discussion, or we won't have a conference. So.
Oh, I know that. But again, for the trainees, I think it's important for them to know that it's very hard to predict from the clinical material what lesion you're gonna find.
Yeah, and that just shows the importance of a biopsy in this disease, and it also shows the importance of even a repetitive biopsy in this disease, because even flares are difficult to predict the lesion, later on in the course, and so that's why you'll meet a lot of lupus patients who will say, again, a third biopsy. Do we have to do this again? And so that actually happens quite a bit in lupus.
And I'm glad, Bill, you brought it up, because Brad Robin with colleagues in Argentina has looked at this item of dissociation between serological findings and histological findings, and the data is there. Whether you accept it or not, it's published, is there.
Yeah, I mean, they're taking it to a step further, that even when you clinically think your patient is in remission, and they've been what you thought would be clinical remission for a while, they're often not in. Yes, Dick.
Let me present you with a hypothetical. Let's say an MPA level was done and it was 0. Would you have put the patient back on MMF under observation and not done the biopsy?
I certainly wouldn't. I think this patient could have used a biopsy a couple of years ago for the exact discussion we just had, because we don't really know what's going on.
Right.
So, no, I think there's a real use for this medication, but no, I don't like empirically treating lupus nephritis unless I don't have any other choice. Any other comments? Or if not, I'll spin the wheel.
Just a quick question. What is the significance of I think it was a positive SSB and a negative SSAA? What does that mean?
Steve, you want to go ahead?
Huh?
The SSA was positive, right? The SSB was negative?
Yeah, SSA was positive, SSB was negative.
Okay, so what does that mean?
Well, at least in our series, when we looked at severe lupus nephritis, that actually, for whatever reason, factored out as predictive of a poor prognosis. And it was kind of interesting. I'm trying to remember the guy that we had worked with from the University of Oklahoma who had done the serology, and he too had found that African-American race SSA were associated with more severe lupus nephritis and a poor prognosis. And I'm embarrassingly blocking the name of the gentleman who did
His name is Seymour Reichland.
Doggone it, Dick. Thank you. Yeah, Dr. Reichland, who did it. And that he had found that independent of us in his own studies, but we found the same thing when we looked at the severe lupus nephritis. And in those, patients, if you remember, they had DPGN, plus they had class 3, but they were really class 4 because they had more than 50% glomeruli involved with segmental lesions. So they weren't pure and simple 3s. They were 3 with greater than 50%. But that was the significance.
So Steve, it predicts a worse lesion or a worse prognosis.
Worse prognosis.
But
Worse
that's
prognosis.
within the proliferative lesions. It doesn't.
Within the patients that had severe lupus nephritis, those that had SSA, those that had a higher creatinine, those that didn't have a DPGN plus or minus 5, which basically meant they had 3 greater than 50%. Those patients did worse.
Yeah. So
amongst all severe lupus nephritis. So it wasn't predicting, these people already had a severe lesion.
all right. That. Oh, great wheel. Tell us who's going to read the biopsy. Faraz. Faraz is one of our first year fellows. Faraz, you're on today, I think.
Can you, Faraz, you hear me?
Yeah,
Yep.
yeah,
Yep, that's you. Move your
Okay.
mouse. Yep, that's you.
perfect. All right. So we've got trichrome stain, 1 core, looking at low power. There's looks like some area of fibrosis up here, maybe a little bit here, but it doesn't look too bad. The tubules in here look pretty packed together. I would say about 30%, 20 to 30% fibrosis.
Yeah, overall it was 40%. So yeah, you're in the ballpark. And in Q, do you see any sclerotic globs? Can you point those out?
There's one right here. There's one here.
Mhm.
Here. There's a bunch.
Yeah, there were 17 glomeruli in the biopsy. 11 were globally sclerosed.
Okay. And then high power H&E. This looks like a sclerosed glom in the middle. Here on the right, it looks like you've got some mesangial expansion. And was this like an old crescent? Some sclerosis?
No, I think that's a little serum protein or something artifactual.
Okay.
Yeah, it's not cellular. It's not scar, because you can
Okay.
see what a scarred glomerulus would look like that. So
Okay.
how about hypercellularity in that glomerulus?
Yeah, it looks hypercellular too. In certain regions, like here, it looks a little hypercellular, but over here it doesn't look hypercellular. It looks expanded, but not hypercellular. And then this glomerulus down here, it looks a lot better. There's lots of open loops. And there's a little bit of mesangial expansion, a couple focal areas of hypercellularity, but otherwise looks pretty good.
So do you see any active lesions of lupus nephritis?
No, I don't see any.
Yeah, good.
Yeah.
Yeah, that's right. Yeah, there's just mesangial expansion and hypercellularity as you described.
Yeah.
David, is that glomerulus that's all the way down to the bottom left of the slide? Are there red cells there in Bowman's space? Is that a glomerulus?
I don't know. It's hard to say. It's right on the tissue edge.
Okay.
Yeah, it looks like. Yeah, I mean, we don't have the glomerulus itself, just part of the hilum, so I can't say for sure what's going
Okay.
on there.
David, Mario, I'm sorry to interrupt. How do you differentiate, going back to whether or not that's a crescent, a pseudocrescent from a crescent? Is the only way looking for disruptions in the GDM that tells you what it is?
Well, cellular crescents are easy to identify. I mean, there's parietal epithelium, more than 2 layers in thickness, involving 25% of the circumference. A fibrocellular crescent, will have a crescent shape. It'll be made of a mixture of cells and fibrosis. So that'd be a mixture of collagen. Yeah, and I would see rupture in the GBM adjacent to the area of crescent. In this particular one, we're probably coming up on a segmental scar or something like that. The color of this looks kind of like proteinaceous material. So yeah, I'm not buying this as a crescent. Yeah, let's go to the next slide.
Okay. Here's another higher power H&E. And you've got a glomerulus in the middle here. We see the same mesangial expansion, a couple focal areas of hypercellularity, but good amount of open loops within the glom. This is probably a sclerosed glom up here. And then the tubules look okay. I don't see a lot of like interstitial, infiltrate or edema. And then is this an arterial?
Where's the pointer? I don't see the pointer.
At 9 o'clock, like all the way on the left.
Yeah, that's an arterial.
That looks okay. It doesn't look hyalinized.
Okay.
Is this a cath?
Yeah, so for us, getting back to the glomerulus, yeah, there's mesangial expansion, hypercellularity, no active lesions. What do you think about the capillary loops?
They look open.
The glomerular basement membrane.
Oh, the basement membrane looks a little thickened.
Mm-hmm. Yeah, especially at 9 o'clock, 10 o'clock.
Yeah, here.
It's yeah, it's thickened. So, I mean, that implies there's something going on in the glomerular basement membrane.
Mm-hmm.
Typically, when we see this diffuse thickening rigidity, we attribute it to membranous lupus. So we'll have to follow that on the special stains and fluorescence.
Okay. If you look at that loop around again 10 o'clock, it actually not only is it thick, it looks a little ratty. Getting to David's point.
Okay. And next slide, we got another high power H&E. Same mesangial expansion, focal areas of hypercellularity, thickened membrane, basement membranes on the loops from what we can see. And then outside of the glomerulus, I've got some infiltrate here on the right side, and an area where the tubules look pretty well packed together, but
so just to the right of the glomerulus and below it, that's all interstitial fibrosis and tubular atrophy.
Mm-hmm.
Could you see the basement membranes of the tubules, how thick they are?
Yeah,
and there's no open tubules where you have that infiltrate. That's all fibrosis, and the tubules above as well.
Yeah, up here.
This is all an area of scar.
Yeah.
David, I have a question. When you see the mesangium that looks so expanded, sometimes I have a hard time kind of figuring out, is that mesangial expansion or is that just mesangial sclerosis from just, that glom is on its way out, kind of scarring? Is it just a color differentiation or is there some other thing you like?
Well, I mean, the majority of loops are all the capillary loops are open here. A glomerulus that's starting to scar down, you have periglomerular fibrosis, you have wrinkling, ischemic changes. I don't see any of those features. This is still a functioning glomerulus.
And the Jones stain, you see a lot of mesangial expansion. I don't see any breaks or ruptures, but lots of spikes and holes, pretty much all over the place. Yeah, like here.
Okay. Yeah. What do we see that? In what condition do we see spikes and holes?
In membranous.
That's right.
Yeah.
Due to subepithelial deposits.
Yeah.
right? That's the basement membrane reacting around the deposit.
Yes, yeah. And then lower power H&E shows a lot of these sclerosed gloms with you know, a lot of fibrosis, and some of these tubules are thinning out and becoming atrophic.
Well, the tubules in the middle are preserved. Those are normal tubules. But down in the bottom left, you could see the hyaline casts, yeah, full of tam-harsel protein. Yeah, those are atrophic tubules surrounded by fibrosis.
Okay.
Yeah, so like I said, over half of the glomeruli were globally sclerosed, as we see here.
So Faraz, you see all that interstitial nephritis to the right? Do you think that's an independent process?
No, it's probably, you know, concomitant and ongoing with the lupus.
Well, with the lupus or the, that would imply that it's independent, that it's, I don't meant independent, I meant, you know, is there acute interstitial nephritis going on? My point is that you can see that kind of, and David will correct me if I'm wrong, but you can see that kind of inflammation around dying glomeruli.
Right.
So I don't think that you can interpret that. Otherwise, that's a, you know, that's a large collection of interstitial cells there. You know, this is a really important slide here because I remember on the very first picture we saw an awful lot of sclerotic glomeruli, and it gets to Dick's point about you know, sitting on something and whether or not I would have just, you know, started treatment or not and felt comfortable with what I had. I think, you know, when you look back at this patient's history, I'm not sure that it could have been altered by a biopsy 2 years ago or not, but this creatinine is fairly deceiving, which is not unusual for renal pathology itself, but there's a lot more fibrosis and glomerular sclerosis than I think most of us typically predict when we see a creatinine like this.
Yeah. And then with immunofluorescence, we got IgG, pretty diffusely granular staining in the capillary walls. Couple areas in the mesangium, it looks like, also.
Mm-hmm. Yep.
And then positive for IgA and IgM. So we've got like a full house consistent with lupus.
Good.
These are the tubules and the interstitium, also staining positive.
Yeah, so in lupus, you get deposition of immunoglobulins in extraglomerular structures, arteries, tubular basement membranes like we have here.
Mm-hmm. And then EM, we've got, let's see, this looks like the mesangium up here. And then the urinary space out here. And then we've got pretty thickened basement membrane and multiple, you know, electron dense deposits all around. And I think this is probably the blood space up here.
Yeah, we're kind of having a hard time seeing the pointer. It's a black pointer on a black and white screen. But yeah, where are some of the deposits? Can you describe?
Click on the screen for us, and I'll change into a laser pointer. Oh, there we go.
Okay. Oh yeah, much better.
There.
Yeah.
That's a deposit.
Okay.
There's some here too. And then
so go to the capillary lumen again.
Right above it on the right.
Oh no. I meant move your pointer to the capillary lumen.
Here.
Well, in the middle of the screen, just down below.
Here or
that's urinary space. Move it to the right.
Oh,
there you go.
This little
that's your capillary lumen.
Okay.
So then the deposits above and below, where are those?
You mean here?
Yeah. Remember, we have a membranous on the immunofluorescence. So what are you expecting to see on the EM?
So you see subepithelial
Yeah.
and intramembranous deposits.
Okay. And then, yeah, and then where are those deposits where you just were? Okay. Okay. Yeah.
Wait, sorry, it's lagging behind. These
Sure. Yeah. Where are those?
intramembranous.
Well, those are mesangial deposits. I mean, that's a mesangial cell just to the left of that deposit.
So are these
There's
the
a-
intramembranous?
yeah, those embedded into the mesangial matrix are mesangial deposits, and then some of those are perimesangial as they loop around to connect to the other loop on the right.
Okay.
Okay, and foot process effacement.
Yeah, it's pretty significant all the way around over up here. I don't see anywhere where it's like preserved.
Around like 5 o'clock, there's a couple. If you keep moving, yeah, there's 2 intact podocytes right there. Yeah.
Okay.
So but it is diffuse. I agree with you. All right, let's have the next slide.
I don't think it's letting me advance. Maybe because it's a laser pointer. Oh, there we go. Okay. So this is the in the middle here is the blood space. Right around on the like top left. To the left is the urinary space. You've got a thickened membrane. And then you've got like electron dense deposits up here, which are sub epithelial.
Yeah, so do you see mostly subepithelial or intramembranous deposits in this loop?
So this one actually looks mostly intramembranous.
Yeah, the deposits are surrounded by basement membrane. And even at like 6 o'clock, you can see some lucent areas. I'm sorry, yeah, and up at maybe 9 o'clock.
Mm-hmm.
Yeah, those are deposits getting reabsorbed. Up just a little bit more, some clear areas. Yeah, there's some resorption of deposits going on as well.
Okay. And then you've got pretty significant podocyte foot process effacement. I don't see any normal ones, maybe one here.
Okay, and how about just point out the mesangial deposits?
Over here on the
Good.
right.
Yep. So just an overall description, a little too far. Do you think this is new membranous or kind of old membranous?
A lot of this looks old. There's
yeah, they're intramembranous. They're getting reabsorbed. Yeah, this has been going on a long time. And look how thick the basement membrane is. We have the marker down there, 2,000 nanometers. Some of these capillary loops are, 2,000 in thickness, like we saw in the H&E, how thick they were.
Yeah.
No big surprise. No big surprise given, the timing of this and how long this has been going on. I'm not saying even if it was treated or untreated, but this is really chronic, severe, lot of intramembranous deposits.
Yeah.
What's
Much more
surprising
than the new ones.
What's
Sorry.
surprising, and I think it goes along with what, I don't know if it was Bill that was making the point, was here's somebody with a creatinine of 0.8, and what percent of her gloms were sclerosed?
11 out of 17.
Yeah, over half. I mean, it just goes to show you what kind of reserve the kidney can have, which gets back to the whole issue of the creatinine itself is not really the best marker of renal function.
All right, so Faraz, right in the X center of the screen, what is that?
Is that a TRI?
Yeah. Can you put the pointer on it? Yeah. Tubular reticular inclusion. It's sitting there in the cytoplasm of the endothelial cell. And then you have some scattered intramembranous deposits with some resorption going on. Yeah, some clearing. Yeah.
we've got, you know, I'd say we've got class 5 lupus nephritis, along with class 4 from the sclerosis.
Yeah. Yeah. Membranous lupus is class 5. And then we have some class 4, which is chronic, globally sclerosed gloms and no active lesions in the biopsy. Okay. Nice job.
Thank you.
Great, great. So let me go to Casey, since you had the original discussion. How do you put this together? What would you do with it?
I never like to discuss treatment of membranous lupus because it's tough. If it was, any of the proliferative lesions, I think it would have been a little easier. So I guess this goes back to the whole point of, was she taking her CellCept? Is she unresponsive to MMF, or did this happen while she was immunosuppressed with MMF? So that becomes a big issue, because if she wasn't taking her medication, I think, that to shut off her serologies, that should help with some of these immune complexes. MMF is not the best agent for membranous. I like Cytoxin. I like, calcineurin inhibitors for primary membranous, Rituxan. But in this particular case, we're talking about lupus. She's got a significant amount of scarring. I would still obviously treat her. Creatinine is still 0.7. She still has quite a bit of function, even though we see a lot of histological fibrosis. So we can bump up her CellCept and, follow, sort of make sure she's compliant to see what happens. There doesn't seem anything active going on right now, so there is no urgency in, induction per se. So we could do that. We could bump up some of her current immunosuppression and stress compliance, or we could switch course and give her Cytoxin. I don't know if she's non-compliant with, and Cytoxin could be given IV or PO. PO I probably wouldn't do. If we don't trust her to take oral MMF, we shouldn't trust her to take Cytoxin. So either IV Cytoxin or oral MMF at a higher dose. And I'm going to go with oral MMF. I just don't see anything that's super active right now for me to pull the trigger on Cytoxin.
Well, I think you hit all the really important points, because we don't really know, is this untreated or inadequately treated or unresponsive? I'm always a little leery that the difference between 3 grams and 2 grams is going to make that much difference. But you never know. I mean, assuming that she took 2 grams, and that is the essence of this case. We don't know if she was treated or not. And there's also the approach that she's got a pretty bad lesion there. She's got a lot of glomerular sclerosis, and maybe it's time to just hit this thing hard, get it over with. And I know that's what, Dr. Lewis would want to do. He would say, this is time for Cytoxin. Let's give her the full induction, turn this disease off once and for all. Dick, what would you do for this patient? Dr. Glassick?
I think with this degree of non-compliance, I wouldn't rely on any oral drug. I don't think the patient has the motivation to take her medications appropriately. So you're looking at rituximab, IV cyclophosphamide. Probably that's the only 2 options. I don't think this is a good case for cyclosporin or voclosporin. I don't think it's a good case for oral cyclophosphamide, and I'm very doubtful she'll take the oral MMF.
So if she was compliant, I remember a paper that you wrote the editorial on some years back. A group from China had written an article about multi-targeted therapy in patients that had lupus membranous with, granted they had a proliferative lesion as well. But if she were compliant, I know that's a big if, would this be someone you would consider giving MMF plus, say, tacrolimus or cyclosporin, or do you still think that maybe cyclophosphamide would be a better drug?
Well, I don't have a good answer for that. And of course, now we have voclosporin in the equation.
Yeah.
I think if you were going to use a CNI, I think the data would suggest voclosporin would probably be a better choice. than tacrolimus or CN. I just think this patient is headed for the dialysis machine, no matter what her serum creatinine is, because she's lost more than half of her nephrons.
Right.
And she has a very chronic process going on. And I agree with Roger, either you decide to try to stop it, the progression, or you just let nature take its course. And I
Dick,
would prefer at her age to try a little harder.
So Dick, you're a evidence-based guy as much as anybody that I know, and that's a compliment. You'd mentioned Rituxan. How would you feel about Rituxan in this case? Do you think that's enough, or would you really prefer? We've given up totally on oral agents, so it's really looks like rituximab or IV cyclophosphamide. How do you feel about the rituximab for lupus membranous?
Well, as an evidence-based person, I'd have to admit there is no evidence for efficacy. All of the data with lupus membranous is observational, but I must say the Rituxaloop study was pretty impressive, and most of the patients in the Rituxaloop study had membranous. But unfortunately, we have no evidence base to fall back on, no randomized controlled trials. So it's all a lot of guesswork. But here, my issue is that this patient is overtly non-compliant. So if you're going to use a drug, you have to, in my opinion, you have to take that into consideration. Just bumping up her MMF to 3 grams a day, how are you going to assure she's going to take it? You can have her come in every month for an MPA level?
Yeah,
Probably yes.
Yeah, well, I think that's off the table. I think we all decided it has to be one of those. It has to be something IV. So
getting to what you're basically bringing up, Roger, and actually Dick too. I mean, is it 6 doses of cyclophosphamide that she may or may not show up, or you take a chance on 2 doses of Rituxan?
Yeah.
I mean, we're going to play the game of, is she compliant? I mean, is she going to be compliant with 2 or 6?
Well, you could probably give her 1 before she leaves the hospital with Rituxan, at least for happen.
And then pray that she shows up again.
And then, as an aside, this is such a good case for why the biopsy is so important, because you could argue if you hear, in the primary membranous of the treatment at this stage would be targeting her proteinuria with an ACE or an ARB. Right, and we're in lupus, so it's a little different. And clearly, seeing this much scarring had to come from the membranous. And so I think that if we don't turn it off, she is as like Dick said, heading for the dialysis unit. And so this would be a case where really an ARB is not enough, even though that's kind of clinically with her proteinuria degree that all that you would start right now. But it shows how important the biopsy is, seeing all that scarring. Knowing
keep in mind what's interesting. She's had lupus. She's had proteinuria for 10 years. I mean, that's kind of the initial, when she presented, what at least I thought we were told, was she had 600 milligrams of proteinuria at that time. And then several years ago had 6 grams. She's gone 10 years and still has a creatinine of 0.8, which again, gets back to the point that the kidney has a fair amount of reserve and she's got a lot of scarring, that a lot of damage has been done over that time period. And possibly if she'd have been biopsied sooner, you might have been able to affect it. But I'm impressed by the fact that for 10 years, she's had evidence of nephritis and her renal function, at least by way of creatinine, is not worse.
I'd love to see her completely treated in another biopsy in a couple of years to see what those basement membranes, just see just how much they can heal. I don't know if anybody knows of any data on that. To see, we know what can happen in proliferative GN, how it can clear up. But I wonder just how, if 2 or 3 years and you get her in remission, her proteinuria goes down and her C3 comes up, and I don't know if her proteinuria will ever go away with that much damage, but I'd love to see those basement membranes in a few years of really.
That's the point. I mean, she's already reabsorbing some of those deposits. You could see were already being reabsorbed, and I think what you're alluding to is exactly. I don't know that you can expect her to achieve a remission as we define it, because I doubt that her proteinuria will ever get down to less than 300 milligrams. With that kind of damage.
Yeah. So Dr. Baxi, why don't you tell us what you did? Walk us through the case.
Yeah, no, exactly what everyone mentioned in terms of treatment. I kind of decided, I had to go through an IV formulation. Her compliance, she said she would miss doses here and there, and I was never convinced that, an oral formulation would be enough. And in terms of her biopsy, so what we did is I went down that path of either Cytoxan or Rituxan, and I was really leaning on Cytoxan. She had a lot of extrarenal lupus, just put an end with it, and we were going to do Euro lupus and just kind of end. She wasn't interested in the Cytoxan, so I ended up doing Rituxan. I did bump her up to 3 grams. I was waiting for approval, which took a little while, and then I gave her 2 doses of Rituxan. I dropped her CellCept down to 2 grams, and I'm just keeping there right now. I don't have any follow-up recently in terms of proteinuria, but her creatinine, it's too early to see, but her creatinine stayed stable at 0.7.8. Her albumin was actually a little higher when I checked it last. It was 3.8, and she's tolerating it well. So, really came down to, what to do here. And, I just want to quickly mention, I think Dr. Rubin mentioned this in the chat already, in terms of, membranous nephropathy and, how far it's come from when we started with, so-called idiopathic to then PLA2R associated, and how this field has really evolved, and it continues to evolve with these new antigens that are being discovered. And, really pertinent to this case will be, the exotosin 1 and 2. But, this is just, again, a schematic that has been shown in previous conferences as well, just showing how this field has evolved. And so, this exotosin story is interesting. And this is a visual abstract that was done for a paper just recently published, May 2019. They looked at PLA2R negative membranous patients. They had 224 patients, and of these 224, they had 26 that were positive exotosin 1 and 2. And of these 26 patients, when you look at the features of these, the biggest thing here is a lot of them had autoimmune features, up to almost 81% of these. And in this paper, when they looked at a validation cohort of 48 patients, of lupus, 8 out of 18 pure membranous lupus patients were positive, along with 1 out of 14 that had a mixed lupus lesion. And the 3 didn't have lupus, but they had other autoimmune features, which was described as certain serological values, but didn't really fit completely into lupus. So there is this kind of autoimmune connection with these antigens of exotosin 1 and 2, which becomes relevant in this case. So what is exotosin?
Sorry, real quick, Pravir,
Yeah.
that's so interesting too, because we think about, of all the lupus cases, membranous lupus nephritis is typically the one that is serologically the most quiescent. So in those autoimmune features, and I hate to put you on the spot, you may not know this, but in those autoimmune features that they had, was a lot of it serology, or was it more just clinical with skin and alopecia and so on?
I think it was more clinical. It didn't specify, and I can go back, but a lot of it just kind of clinical, more or less. I think it's more clinical manifestations versus serological. And, they didn't have, other thing I should mention, none of these patients had any circulating antibodies, which was another big point there. But yeah, no, it was interesting there. And so what is exotosin? I mean, it's basically, these exotosin are glycosyl transferases that are responsible for the synthesis of the heparan sulfate backbone, which eventually gets transported into our GBMs. And these are ubiquitously expressed proteins. There's 5 genes that are responsible, and they're transmembrane proteins. And so they localize to the endoplasmic reticulum, and they distribute to the Golgi apparatus, and where the biosynthesis of heparan sulfate occurs. And so there is a hereditary multiple exostosis syndrome, basically, that it's one of the most common inherited skeletal disorders. So there is a back history of this, but this story in membranous is interesting, and this is what Dr. Rubin was mentioning. The recent paper, just March of this year, that becomes pertinent in our case, is looking at specifically membranous lupus nephritis, and does exotosin positivity versus negativity have any type of bearing? And it does. It's thought, at least it's thought, this is early, that there are 2 different phenotypes. And so in this study, not to go in too much depth, but they looked at 374 biopsy proven membranous lupus patients, and about a third of them had exotosin positivity. And of these, the majority were pure lupus membranous, and there was a small subset who had a mixed proliferative and lupus lesion. And when you looked at these, if you look at specifically the patients who were positive, they had a little lower serum creatinine on presentation that was statistically significant. They had more proteinuria on presentation as well, greater than 3.5 grams. So these were more nephrotic on presentation than those that were exotosin negative. And finally, they had less glomeruli that were scarred. So they had less IFTA and less sclerosed glomeruli as compared to the exotosin negative patients. And when you look at the outcomes of these, so this is of all patients who had not just pure lupus membranous, but also those with membranous with a proliferative lesion, looking at exotosin positivity versus exotosin negativity. If you look at the overall progression to end-stage kidney disease, those that were exotosin positive had less progression. And so as was mentioned in the chat, these patients may have, a better phenotype type, even though when they present with more proteinuria typically on presentation. So less glomerulosclerosis, which goes into likely why they had less progression to end-stage kidney disease. And so one of the outcomes of the statements of this paper was that, these suggest that the presence of these antigens is favorable, and this was specifically in membranous lupus. So why is that? I don't think we know, but at least in this paper, the authors hypothesized that these exotosin positive patients, there's increased secretion of the catalytic domain of these antigens into the GPM, and that allows more increased production of heparin sulfate. And this increased production is thought to potentially offer protection from leukocyte infiltration, complement activation, and cytokine production. And maybe that's why these patients had a better potentially prognosis than those that were exotosin negative. So that's just a new stuff that's just out there. I think the story on this is still left to be kind of unraveled, but it is interesting, and it was kind of pertinent to our discussion of this patient. So again, I chose to do Rituxan, and I'm keeping her on a low dose of CellCept along with an ARB, and we'll kind of see how she ends up kind of progressing. But I think it is overall, unfortunately, a poor prognosis given how much scarring she already has. But I couldn't treat her. I wanted to treat her given her age and all that positivity that we saw.
Yeah, well, that's very useful. It'll be fun to get some follow-up on her. Eventually we're going to have some special sessions where we have nothing but follow-up on some of these more difficult cases. We'll have that in the future. David, is there any possibility we're going to be able to stain for exotosin?
I'll keep my eye out. If something comes commercially available, we'll certainly get it in our lab.
So that's the issue, because some of the other places can do it, but it's not a commercially available stain.
Right.
Is that the okay?
Yeah. Same with thrombospondin.
Yeah. Well, it would be nice. Like I said, it wouldn't change that much in this case. Certainly thrombospondin and some of the others might help as far as how aggressively we look for malignancy, et cetera. Great. Well, thanks everybody. Any other comments? Otherwise, we'll shut this off. It's 2:05. Another great conference. Appreciate everybody joining us today. We're going to have the next 3 weeks off. We've got National Kidney Foundation, and we have the fellows ASN practice exam. So we'll be off for a few weeks. Just follow your emails, follow us on Twitter, and we'll let you know when the next conference is. Today's CME activity code is 481831. You have 3 days to sign up. Great job, and I appreciate everybody's input, and have a safe weekend. Thank you.